Welcome to the deep dive. Today we're tackling compartment syndrome.
That's right.
Our sources are chapters from Rutherford's vascular surgery and endovascular therapy, and our goal really is to pull out the crucial information.
What it is, why it happens.
Exactly how it's spotted, what can be done, and keep it clear and engaging.
Get you the essential knowledge without getting bogged down in overly technical stuff.
Right. Think of this as your, let's say, fast track to understanding a really significant medical situation.
Yeah, these chapters give a solid expert-level view. Very comprehensive.
So why should you tune in? Well, maybe you're prepping for a medical discussion, or you're just curious about how the body reacts to injury.
Or simply want to understand a potentially critical condition.
This deep dive will definitely equip you with key insights. Some might even surprise you.
Absolutely.
Okay, so let's dive right in. What exactly is compartment syndrome at its core?
Well, simply put, it's when pressure builds up dangerously high inside a muscle compartment. These compartments, they're groups of muscles, nerves, blood vessels, all wrapped up by this tough layer called fascia.
Right, like a tight container.
Exactly. And when the pressure inside gets too high, it squeezes the blood vessels.
Impeding blood flow.
Yes, hindering blood flow and potentially damaging the tissues inside. Muscles, nerve.
So like putting way too much into a sealed box.
That's a pretty good analogy, actually. And to really grasp how the pressure affects blood flow, think about blood vessels as tiny pipes.
Okay.
There's this principle, Poiseuille's law, which basically tells us that even a small bit of external pressure squeezing on that pipe.
Squeezing the vessel.
Yeah, squeezing the vessel. It can dramatically reduce blood flow, partly because it narrows the radius, the R in the equation.
Like stepping on a garden hose.
Right.
Even a little pressure makes a big difference.
Exactly that. It reduces the flow significantly. It also impacts the pressure difference driving the flow.
Okay, so the pressure clamps down. Now, how do doctors figure out when that pressure is too dangerous? I remember hearing about like a specific number.
Right. There was an early concept about a critical closing pressure. The idea was at a certain absolute pressure, the capillaries would just collapse.
Makes intuitive sense.
It does, but later research, like studies by Hartsock, kind of disproved that simple idea. It showed it's more about the difference between the pressure in the arteries supplying blood and the pressure inside the compartment.
Ah, the arterial venous pressure gradient.
Precisely. That gradient, that CALAP, is what drives flow. If the compartment pressure, ICP, gets too high, it reduces that gradient, even if the vessels haven't fully collapsed.
Interesting. So it's not just one magic number.
Not really, no. While early animal studies, Hargens' work for instance, did find that a specific pressure, like 30 mmHg for 8 hours, could cause muscle death in dogs.
Okay.
What's proven more useful clinically is this idea of a dynamic threshold.
Dynamic meaning.
Meaning you have to consider the patient's own blood pressure. So how high is the compartment pressure relative to their mean arterial pressure, MAP, or their diastolic pressure?
Right.
Yeah, researchers like Heppenstall and Heckman found that looking at these differences, like MAP minus ICP or diastolic minus ICP, were better predictors of trouble.
Oh, so if the difference is too small, that's the danger zone.
Exactly. For example, if the MAP minus ICP drops below 40 mmHg in injured muscle, or the diastolic minus ICP is less than 10 mmHg, these dynamic thresholds help avoid unnecessary surgery, fasciotomies.
Because the absolute pressure might be up a bit, but if the patient's blood pressure is also high, there might still be enough flow.
Precisely. There's still an adequate driving pressure.
That makes a lot more sense clinically. Okay, so we know high pressure is the core problem. But what actually causes this pressure to build up? What are the root causes?
We can broadly categorize them into vascular causes and non-vascular causes.
Okay, let's start with vascular.
A really major one is ischemia reperfusion injury, IR injury.
Ah, yes, we've talked about that. Blood flow gets cut off, then restored, but the restoration itself causes damage.
That's the one. In compartment syndrome, this often happens after, say, an acute arterial blockage is fixed, or following severe crush injuries.
How does that raise pressure?
Well, the initial lack of oxygen damages the small blood vessels, the capillaries, makes them leaky.
Okay.
Then, when blood flow returns, reperfusion fluid leaks out of these damaged capillaries into the muscle tissue.
Causing swelling, edema.
Exactly. Edema within that tight fascial compartment. And that swelling drives the pressure up. Oxygen radicals generated during reperfusion make it even worse.
Are there known risk factors for this IR-related compartment syndrome?
Yes. Studies like one by Orpin, have identified some. Things like inadequate backflow after restoring circulation, high levels of creatine kinase, CK, indicating muscle damage, a positive fluid balance in the patient, and of course, how long the ischemia lasted.
Okay, so the body trying to fix the blood flow issue can actually trigger this pressure problem. What other vascular issues?
Trauma is a big one. Direct injury to arteries or veins.
How does that work?
Arterial injury often leads back to that ischemia-reperfusion cycle we just discussed. Cut off blood flow, then maybe it gets restored surgically, leading to swelling.
And venous injury.
Venous injury messes up the drainage. If blood can't get out of the compartment efficiently because the veins are damaged or blocked, pressure builds up from the back end, essentially.
Okay.
And interestingly, the data shows that fasciotomy rates are higher with injuries to the popliteal artery, the one behind the knee, compared to injuries higher up, like the femoral artery. Potentially less collateral circulation around the knee. Then there's venous outflow obstruction from other causes, like a massive deep vein thrombosis, DVT.
A big blood clot.
A very extensive one, yes. Usually needs to block not just the main vein, but also the smaller collateral veins that would normally provide alternative drainage routes.
So the blood just can't get out.
Right. It increases the pressure in the veins, which narrows that crucial arterial venous pressure gradient needed for capillary flow.
Where might you see this?
We sometimes see it, unfortunately, after procedures like harvesting a leg vein for bypass surgery, or during ECMO when large cannulas in the femoral vein obstruct flow. The incidence rates are documented, though thankfully not super high.
Okay. Any other vascular causes?
Hemorrhage. Bleeding directly into the compartment.
From what?
Could be a ruptured aneurysm, maybe a popliteal artery aneurysm bursts, or bleeding after surgery, particularly if the patient is on anticoagulants, blood thinners. That can cause a rapid pressure increase.
Okay, so blockages, leaks, trauma, bleeds. Lots on the vascular side.
Yeah.
What about non-vascular causes?
Fractures are probably the most common overall cause, especially fractures of the tibia, the main lower leg bone, and the forearm bones.
How does a broken bone cause it?
Well, the fracture itself injures the surrounding muscle, and it causes bleeding directly into the compartment. Both contribute to swelling and pressure.
Makes sense. Does the type of fracture matter?
It seems to. Incidence rates vary quite a bit, reported anywhere from 1 to 29%. Comminuted fractures, where the bone is broken into multiple pieces, tend to carry a higher risk. More trauma, more bleeding.
And certain locations are more vulnerable?
Yes, the anterior compartment of the leg and the volar or flexor compartment of the forearm seem most susceptible after fractures in those areas.
Okay, fractures.
What else? Crush injuries are another major one. Direct, prolonged compression of muscle tissue.
Like in accidents. Building collapses.
Exactly, or industrial accidents, heavy objects falling on a limb. The mechanism here is sort of twofold. Direct muscle damage from the crushing force, and then that ischemia-reperfusion injury kicks in when the compression is released.
Ah, the reperfusion again.
Yes. And it's worth noting, sometimes aggressive fluid resuscitation with crystalloids in these patients, while necessary for other reasons, can sometimes exacerbate the swelling and compartment pressure.
Good point. Anything else non-vascular?
There are iatrogenic causes, things resulting from medical care itself.
Like what? Give me some examples.
Things like fluid extravasation, where IV fluid leaks out into the tissue instead of the vein. Certain caustic medications, like contrast agents, if they leak out. Accidental injection into an artery.
Ouch.
Yeah. Bleeding from arterial or venous punctures in patients with clotting problems. Even prolonged immobilization during surgery, especially in positions like the lithotomy position used for pelvic surgery.
Really? Just from positioning?
It can happen, yeah. External pressure over a long time, even just a tight cast applied after a fracture can sometimes contribute if swelling occurs underneath it.
Wow.
And lastly, there's a rare entity called secondary compartment syndrome.
Secondary?
Meaning it happens without direct trauma to the limb itself. It's seen in critically ill patients, often related to a massive systemic inflammatory response, like in sepsis, combined with huge volumes of fluid resuscitation. The idea is that capillaries everywhere become leaky, including in the limbs.
Fascinating. So it sounds like a whole host of things can lead to this pressure buildup. Given that, how does someone know if they might have it? What are the key signs, the symptoms to watch for?
The classic #1 symptom is pain. But not just any pain. It's pain that seems way out of proportion to the injury itself.
More pain than you'd expect.
Much more. And critically, it's often poorly relieved by just immobilizing the limb or by standard doses of opioid analgesics.
Okay, disproportionate pain. What else?
Paresthesias, that's tingling, pins and needles sensations, or numbness. These are often early signs that the nerves within the compartment are starting to suffer from the lack of blood flow, the ischemia.
So pain and nerve symptoms. What would a doctor look for on examination?
Well, the affected compartment itself often feels very tense, swollen, maybe even described as rock hard on palpation.
Feeling the limb.
Yes. And another key finding is pain with passive stretching of the muscles within that specific compartment.
Passive stretching.
Meaning, the examiner gently moves the patient's limb to stretch those muscles. For example, flexing the patient's foot downwards stretches the muscles in the anterior compartment of the leg, and that would cause significant pain if that compartment is involved.
Got it.
A really thorough neurologic exam is also vital. Checking sensation, light touch, maybe two-point discrimination, and muscle strength in the areas supplied by the nerves running through those compartments.
Can you give an example?
Sure. For the anterior leg compartment, the deep peroneal nerve runs through there. So you check sensation in the first web space between the big toe and the second toe, and test the strength of toe and ankle extension, lifting the foot up. Weakness or numbness there points towards that compartment.
Loss of two-point discrimination, being able to tell if you're being touched by one point or two close together, that's a sensitive sign.
It can be, yes, considered quite sensitive for early nerve ischemia. However, and this is important, clinical findings alone, while crucial, aren't foolproof. A meta-analysis by Ulmer, specifically looking at tibial fractures, found the overall sensitivity and positive predictive value of these classic signs were actually quite low.
Meaning, having those signs doesn't guarantee you have compartment syndrome.
Correct. Or, put another way, some people with compartment syndrome might not show all the classic signs, especially early on.
But what about the flip side? If the signs aren't there?
That's where clinical exam is more helpful. The negative predictive value is high. If a patient has none of these key features, no disproportionate pain, no pain on passive stretch, normal neuro exam, then compartment syndrome is much less likely. It helps rule it out.
So absence of signs is reassuring, but presence of signs means you need to investigate further.
That's a good way to put it. And because the clinical picture can be equivocal, or if the patient can't communicate reliably, maybe they're unconscious, intubated, or a young child, that's when measuring the compartment pressure directly becomes really valuable.
Measuring the ICP.
Right. But if the clinical diagnosis is crystal clear based on history and exam, measuring pressures might just waste valuable time and delay the definitive treatment, which is fasciotomy.
Okay, so it's a tool for specific situations. When they do measure the pressure, how is that actually done? What's the technique?
There are a few different instruments: simple manometers, specialized catheters and needles, even fiber optic transducers.
Like checking tire pressure, but for your leg.
Sort of, yeah. A needle or catheter is carefully inserted into the muscle compartment you're worried about. It's then connected to a device that reads the pressure.
What systems are common?
Probably the two most common are using a standard arterial line setup, the same kind used for continuous blood pressure monitoring, just connected to the needle in the compartment, and handheld, self-contained devices like the Stryker system.
And where do they stick the needle?
It's guided by the clinical exam. You'd prioritize the compartment that feels the tightest or is most symptomatic, often the anterior leg or the volar forearm.
Just one measurement.
Not always. It's often advisable to measure all compartments potentially at risk in that limb segment. And sometimes multiple readings over time might be needed, especially if the situation is evolving.
Is continuous monitoring a thing?
It is. McQueen and colleagues found continuous monitoring had high sensitivity, specificity, and negative predictive value. However, another study by Harris in alert patients with tibial fractures didn't show it actually improved outcomes compared to clinical monitoring plus selective single measurements. So the jury's still out on its universal benefit.
What gets recorded?
You record the intracompartmental pressure, ICP, but it's crucial to also record the patient's mean arterial pressure, MAP, and diastolic blood pressure at the same time.
For those dynamic thresholds we talked about.
Exactly, to calculate those critical differences. And just for reference, normal resting ICP is generally considered to be low, around 10 to 12 millimeters of mercury, or even less.
Are there non-invasive ways to check?
Near-infrared spectroscopy, NIRS, is probably the most studied non-invasive method. It measures tissue oxygenation, it shows promise, but it still requires more validation before it can replace direct pressure measurement in most cases.
Okay. And you mentioned earlier, this isn't just a leg problem. Where else can it show up?
Absolutely. It can happen in pretty much any distinct myofascial compartment: upper extremity, forearm, hand, thigh, foot, even the buttock.
Same basic signs, pain and swelling.
Yes, the hallmark is usually pain out of proportion to the injury and noticeable swelling or tenseness in that area. Neurologic symptoms can be variable depending on which nerves are compressed.
Like in the hand.
The hand has about 10 compartments, believe it or not. So after crush injuries or maybe carpal fractures, you can get compartment syndrome there. It causes pain and paralysis of the small intrinsic muscles.
On the forearm.
Common after direct blows, crush injuries, fractures like we mentioned. Again, pain, swelling, and symptoms related to the median, ulnar, or radial nerves. Usually results from significant blunt trauma like car accidents, severe contusions, or crush injuries. The anterior compartment, the quads, is most common. Pain on passive knee flexion, maybe paresthesias or paralysis from femoral nerve involvement. Interestingly, reperfusion injury seems less of a major factor in thigh compartment syndrome compared to the lower leg.
And the buttock. That sounds unusual.
It is less common, yeah. It's been associated with things like internal iliac, hypogastric artery ligation or embolization during pelvic procedures, sometimes after hip replacement surgery, or even just prolonged compression during long operations. It can be serious, leading to rhabdomyolysis, kidney failure, and potentially sciatic nerve palsy.
So really need to keep it in mind for various body parts. Okay, switching gears a bit. Can we prevent compartment syndrome? Are there measures people can take?
Well, there's been research into pharmacologic prevention, mostly focused on blunting that oxygen radical formation during reperfusion after ischemia.
What kinds of drugs?
Things like mannitol, allopurinol, superoxide dismutase, deferoxamine, agents targeting thromboxane A2, even melatonin.
Have they worked?
Mostly, these studies have been in animal models. There's limited human data, maybe some case reports or small series suggesting benefit, but nothing definitive from large trials yet. So no standard pharmacologic prevention strategy exists right now.
What about managing a situation where you suspect it's about to develop, like impending compartment syndrome?
There's a sort of protocol outlined by Mars. The key elements are maintain normal blood pressure to support perfusion, remove any constricting bandages or casts immediately, position the limb at the level of the heart critically, not elevated high above it.
Why not elevated? Isn't that standard for swelling?
Normally, yes, but in this case, elevating the limb too much can actually lower the arterial pressure supplying it, potentially worsening the ischemia if compartment pressures are already high. So heart level is preferred.
Okay, heart level, what else?
Supplemental oxygen is also recommended, and specifically for prevention during long surgeries in the lithotomy position, like some pelvic surgeries.
Yes, you mentioned that earlier.
Some suggest that if the surgery is over 4 hours, the leg should be lowered below heart level for about 15 minutes every 4 hours to improve perfusion.
Interesting practical tip. Now, what about preventing the systemic problems that can arise from compartment syndrome, especially if there's significant muscle damage?
Right. The myonecrosis can release potassium and myoglobin into the bloodstream. Big problems.
Hyperkalemia and myoglobinuria.
Exactly. Hyperkalemia, high potassium, can be life-threatening, causing cardiac arrhythmias. This is a major risk with extensive muscle death, like in severe crush injuries. It needs aggressive pharmacologic treatment and sometimes even urgent hemodialysis or hemofiltration to remove the potassium.
And the myoglobin.
Myoglobin released from damaged muscle is toxic to the kidneys. It can cause renal vasoconstriction, form casts that block the kidney tubules, and directly injure tubular cells. This can lead to acute kidney injury, renal failure.
How is that managed?
The mainstay is aggressive IV fluid hydration with crystalloids to maintain a high urine output, essentially trying to flush the myoglobin through the kidneys.
What about forcing diuresis or changing urine pH?
There was thought that using diuretics like mannitol, forced diuresis, and making the urine alkaline with sodium bicarbonate might help prevent myoglobin toxicity. However, a review by Brown and colleagues suggested there wasn't really a difference in outcomes compared to just aggressive hydration alone.
So just lots of fluids.
Current recommendations generally focus on aggressive hydration, aiming for a urine pH above 6.5 if alkalinization is used, but hydration is key. Standard hemodialysis isn't very effective at removing myoglobin because it's a large molecule. Continuous venovenous hemofiltration, CVEH, might be better, but it's often reserved for patients who need renal replacement therapy for other standard indications anyway, like severe hyperkalemia or fluid overload.
Okay, so manage the systemic fall aggressively. But when acute compartment syndrome is diagnosed, what's the definitive treatment for the compartment itself?
The only known effective treatment for established acute compartment syndrome is a surgical procedure called fasciotomy.
Cutting the fascia.
Precisely. Making incisions through that tight fascial layer to release the pressure. It's absolutely crucial that the technique is adequate to fully decompress all affected compartments and to avoid injuring nerves and vessels during the procedure.
And how do surgeons decide when it's necessary? You mentioned clinical signs and pressures. Are there clear criteria?
Yes, often summarized in tables, like Table 105.1 in Rutherford's. There are absolute indications, meaning fasciotomy is definitely needed.
Such as?
A tense, swollen compartment PLUS, either significant pain with passive muscle stretch or developing paresthesias or muscle weakness, paresis.
Okay.
Also, a tense compartment in a patient who can't be reliably examined like an unconscious patient is generally considered an absolute indication.
And based on pressure measurements?
If the measured intracompartmental pressure, ICP, gets too close to the patient's blood pressure, specifically if the MAP minus ICP difference is less than 40 mmHg, or if the diastolic BP minus ICP difference is less than 10 mmHg.
Those dynamic thresholds again.
Exactly. Those are generally considered absolute indications for fasciotomy based on pressures.
Are there situations where it's not so clear-cut but still might be done? Potential indications?
Yes. For example, after prolonged acute ischemia, say longer than 6 hours, especially if collateral blood flow isn't great, or with combined arterial and venous injuries as the risk is high.
Makes sense.
Also in cases of phlegmasia ceruleus dolens, which is a severe form of DVT causing limb ischemia, and often considered when a compartment is clearly tense after a significant crush injury or a major fracture, even if other signs aren't fully developed yet.
Sort of a prophylactic fasciotomy?
You could call it that, yeah. It's really about anticipating the likely progression of swelling in high-risk situations. Sometimes the clinical criteria alone are sufficient to make the call without needing pressure measurements.
Are there times when you wouldn't do a fasciotomy? Contraindications?
The main one is if the extremity is clearly non-viable, extensive tissue death or damage from trauma or prolonged ischemia where salvage isn't possible. Amputation might be the necessary route there. Also, as we touched on, extreme caution is needed in severe crush injuries because releasing the pressure suddenly can cause a massive flood of potassium and myoglobin into the system, which can be lethal. The risks and benefits need careful weighing.
Right. So, assuming fasciotomy is indicated, can you give us a sense of the surgical technique? How was it actually performed? Let's start with the lower leg.
Okay. The lower leg has 4 compartments: anterior, lateral, superficial posterior, and deep posterior. Surgeons need to be very mindful of the anatomy, especially the superficial peroneal nerve, which is vulnerable near the fibula.
Incisions.
The skin incisions need to be long, typically 12 to 20 centimeters, to allow for full decompression of the underlying fascia. There are 2 main approaches.
Which are?
The double incision technique is probably more common among vascular surgeons. It involves 1 incision on the lateral outer side of the leg to release the anterior and lateral compartments, and a separate incision on the medial inner side to release the superficial and deep posterior compartments. There are specific steps to identify and protect nerves and vessels.
And the other technique?
That's the single incision technique, usually a long lateral incision over the fibula. You raise skin flaps and have to carefully dissect around the fibula, sometimes even partially removing the periosteum, to reach all 4 compartments. It's technically more demanding and carries perhaps a slightly higher risk to the peroneal artery and nerve.
So double incision is generally preferred.
Often, yes.
What about the thigh?
The thigh has 3 main compartments: anterior quadriceps, posterior hamstrings, and medial adductors. Usually a single long lateral incision is sufficient. You incise the iliotibial band and the septum between the anterior and posterior compartments, then retract the vastus lateralis muscle. The medial compartment rarely requires separate decompression, but if needed, a separate medial incision would be used.
Buttock.
3 muscles, essentially 3 compartments. A longitudinal incision is most frequent, allowing decompression of all muscles and potentially exploration or release of the sciatic nerve if needed.
And the foot. Sounds complex.
It is. The number and exact definition of foot compartments can vary, but generally include medial, lateral, central, or superficial, calcaneal, and multiple interosseous compartments between the metatarsal bones. Typically requires 2 dorsal, top of the foot, longitudinal incisions, plus often a separate medial incision for the calcaneal compartment. Care is needed to avoid the plantar nerves and vessels.
Okay, moving to the upper extremity, the forearm.
The forearm has 3 compartments: volar, flexor muscles on the palm side, dorsal, extensor muscles on the backside, and the lateral mobile wad. A single, often curved incision on the volar side, the classic Henry approach, can usually decompress the volar and lateral compartments effectively.
What about the dorsal side?
If dorsal compartment pressures are also elevated, a separate longitudinal incision on the dorsal aspect is needed. Whether to routinely release the carpal tunnel at the wrist during a forearm fasciotomy is a bit controversial if it's isolated forearm syndrome, but often done.
And the hand. You said that's rare.
It is rare and complex with its 10 compartments. The approach is usually tailored to the symptoms. Carpal tunnel release is generally indicated. Most will need decompression of the interosseous compartments via dorsal incisions, and possibly releases of the thenar, thumb side, and hypothenar, pinky side compartments through separate palmar incisions. Usually longitudinal incisions are used.
Wow. Okay. So the surgery releases the pressure. What happens with those open wounds afterwards? How are they managed?
Good question. The immediate goal after fasciotomy is to protect the exposed tissues and allow the swelling to go down without causing further injury.
Ow.
Often, the wounds are initially covered with simple saline moistened dressings. This allows for easy inspection and any necessary debridement, removal of dead tissue, usually done back in the operating room every couple of days.
Are there other options?
Yes, vacuum-assisted closure, or VAC therapy, is frequently used. It applies negative pressure through sponge dressing. It can help manage drainage and potentially promote granulation tissue, but the wounds still need regular inspection underneath.
Then what? When does closure happen?
Once the muscle looks viable and the swelling has significantly subsided, the priority shifts to closing the fasciotomy wounds.
How's that done? Several ways.
Yes, several approaches. Delayed primary closure, basically stitching the skin edges together surgically a few days later, is one option, though some studies suggest caution as it might increase compartment pressure again slightly.
Okay.
Allowing the wound to heal by secondary intention, just letting it fill in on its own, is possible but very slow and leaves large scars. More commonly, techniques are used to gradually bring the skin edges together over days or weeks using things like vessel loops woven like shoelaces, sutures, or commercial skin stretching devices.
And skin grafts.
Split thickness skin grafting, STSG, is very common, especially for larger defects. If primary closure isn't possible after the first or second washout, early skin grafting is often recommended. Sometimes more complex flaps involving muscle and skin are needed if important structures like nerves, vessels, or bone are exposed.
Is earlier closure better?
Generally, yes. Earlier definitive wound closure seems to be associated with fewer wound complications and shorter hospital stays. There's debate about the best method, VAC versus shoelace techniques. For example, studies show mixed results. Interestingly, children seem more likely to achieve delayed primary closure compared to adults.
Okay, so wound management is a whole process itself. Looking at the bigger picture, what are the typical outcomes after a fasciotomy? Short term.
Well, even with successful fasciotomy, it's not without risks in the immediate aftermath. As mentioned in some studies, mortality rates, particularly for calf fasciotomy, which often occurs in very sick or injured patients, can range from 11 to 15%.
Wow, that high.
It reflects the severity of the underlying conditions often associated with it. Major amputation rates are also significant, reported between 5 and 21%.
And complications.
Wound complications, infection, skin necrosis, graft loss are relatively common, maybe 4 to 38%, and seem more frequent if the fasciotomy was delayed more than 6 hours. Acute renal failure is rarer unless there was significant underlying muscle necrosis from the initial injury. Neurologic deficits are unfortunately common, reported in 7 to 36% of cases, and are the most frequent early complication after forearm fasciotomy.
So significant potential downsides, even with treatment. What about long-term outcomes?
Long-term outcome is largely determined by the functional status at discharge. Obviously, early neurologic deficits or an amputation predict long-term disability.
But even without those major issues.
Even without those, a fasciotomy itself can lead to long-term problems. Studies, like one by Fitzgerald, found issues like altered sensation or numbness around the wound margins in a high percentage, maybe 77%. Tethered tendons limiting movement can occur. Recurrent skin ulcerations over the scars happen in maybe 13%.
What about leg function?
Chronic venous insufficiency is a known long-term issue after lower leg fasciotomy, reported in almost half of patients in one study by Bermudez. It's thought to be due to damage to the calf muscle pump mechanism.
And late amputation.
Sadly, yes. Some studies show a late amputation rate of around 7.5% occurring between 30 days and 1 year after the initial event.
That's sobering. Now, what about the flip side? What happens if compartment syndrome is missed or treatment is significantly delayed?
The consequences are often devastating. A delay dramatically increases the risk of permanent neurologic deficit, the need for amputation, and systemic complications like renal failure.
How much of a delay matters?
A classic study by Sheridan and Matson showed that delaying fasciotomy beyond 12 hours led to a complication rate of 54% compared to just 4.5% if done earlier. Nearly half of those delayed cases required amputation, and almost all had significant residual neuropathy.
And waiting even longer.
Delays beyond 36 hours almost invariably lead to amputation or a non-functional limb. As we mentioned, performing a decompression after about 3 or 4 days is generally not indicated because the muscle is likely already dead, and the risk of infection and complications from releasing necrotic tissue is very high.
What's the classic long-term problem from missed compartment syndrome?
That would be Volkmann's ischemic contracture.
Volkmann's contraction.
Yes. The ischemic muscle and nerve tissue die and are replaced by dense fibrous scar tissue. This scar tissue contracts over time, pulling the joints into a fixed, deformed position, often a claw-like hand or a foot drop. The limb becomes stiff and immobile.
Can that be treated?
Treatment is difficult. It usually involves extensive surgery to release the contracted scar tissue and sometimes the joint capsules. Orthopedic consultation is definitely needed for managing these late sequelae.
Really underscores the need for timely diagnosis and intervention. Okay, let's shift gears one last time to chronic exertional compartment syndrome, CECS. It sounds different.
It is quite different, yes. CECS is about exercise-induced pain and tightness, not usually related to acute trauma.
Where does it typically occur?
Most commonly in the lower leg, especially the anterior and lateral compartments.
What causes it?
It's thought to be due to increased muscle volume during exercise within a non-compliant fascial compartment, leading to a temporary rise in intracompartmental pressure and transient ischemia or lack of blood flow.
Who gets this?
Typically, young, athletic individuals. Runners are classic examples.
What are the symptoms like?
The key is the pattern. Pain and tightness come on during exercise, usually after a predictable duration, maybe 20-30 minutes. It forces them to stop. Then, importantly, the pain resolves relatively quickly with rest, usually within 15-30 minutes.
Any other symptoms?
Sometimes associated paresthesias, tingling or numbness, or even temporary muscle weakness or foot drop during the episode. Interestingly, symptoms are bilateral, affecting both legs. In a large majority of cases, maybe up to 82%.
What about the exam?
Between episodes, the physical exam is often completely normal, though there might be some tenderness over the affected compartments.
How is it diagnosed definitively, differentiating it from things like shin splints or stress fractures?
That's the challenge. The differential diagnosis includes fascial hernias, medial tibial stress syndrome, shin splints, nerve entrapments, popliteal artery entrapment syndrome. While history is key, the gold standard for diagnosis requires measuring intracompartmental pressures.
But measuring them differently than for acute syndrome.
Yes. For CECS, pressures are measured at rest, immediately after provocative exercise that reproduces the symptoms, and then again at 1 and 5 minutes post-exercise. There are specific pressure criteria originally proposed by Pedowitz and later modified by others like Roscoe using continuous monitoring during exercise.
What are those criteria generally?
They involve elevated pressures either at rest, for G, 15 mmHg, or more significantly, markedly elevated pressures immediately post-exercise, gentle 30 or 35 mmHg, that remain elevated even after several minutes of rest, e.g. 20 mmHg at 5 minutes.
So, if diagnosed, what's the treatment for CECS?
Well, non-operative treatment involves activity modification, basically avoiding the activities that cause the pain. For many athletes, that's not really an acceptable long-term solution.
So surgery.
So surgical decompression fasciotomy is often the preferred treatment, especially for athletes wanting to return to their sport.
Is it the same fasciotomy as for acute syndrome?
Similar principle, but usually only the specific compartments identified as symptomatic and having abnormal pressure readings are released. The incisions can sometimes be smaller, using minimally invasive subcutaneous techniques with specialized knives, or sometimes a more formal fasciectomy is done, actually removing a strip of fascia rather than just cutting it.
And how well does that work for CECS? What are the outcomes?
Generally, the results are quite promising. Long-term studies show significant pain reduction and high rates of return to sport, often over 80% success rates, particularly for anterior compartment release.
Does the pressure correlate with pain?
Yes, studies have shown a positive correlation between the measured ICP levels and the patient's reported pain levels.
Any difference between doing one leg versus both?
Outcomes seem similar for staged unilateral versus simultaneous bilateral fasciotomies. However, outcomes are generally worse if the fascial release is incomplete. Making sure all involved compartments are adequately decompressed is key.
This has been incredibly thorough. A really deep look at compartment syndrome, both acute and chronic exertional types. Just to recap maybe a few key takeaways.
Sure.
Acute compartment syndrome is a true limb-threatening emergency caused by that increased pressure in muscle compartments. Timely diagnosis, often combining clinical suspicion with pressure measurements, is critical.
And fasciotomy, surgical decompression, is the definitive treatment when indicated.
Right. Understanding the underlying mechanisms, the many potential causes from trauma to iatrogenic issues, and the importance of those dynamic pressure thresholds is really vital.
Absolutely. And CECS, while related by pressure, is a distinct entity primarily affecting athletes, usually managed effectively with targeted fasciotomy if conservative measures fail.
It really highlights that delicate balance within our body's compartments.
It certainly does.
Okay, so to wrap up, here's a final thought for you, our listeners. Given what we've discussed about both the acute, sudden onset form and the chronic, exercise-induced form of compartment syndrome, how might a deeper understanding of individual physiological responses to stress, injury, and exertion potentially lead to earlier recognition and maybe even more personalized management strategies in the future? Something to think about. Thanks for joining us for this deep dive.